off with a very important topic. I will just briefly introduce Sharif, who in many ways needs no introduction to the vast majority of us. But you may not know that he did a PhD in pharmacology at Queen's before doing his medical degree in Calgary, internship in Toronto, and finally residency in Ottawa. Now, he joined the Ottawa Institute in 1995, and he was residency program director there. So his knowledge of that has really helped me as a mentor over the years. And he was chair at Queen's for 8 years before heading over to us, where he was not tired of being chair yet, and he's heading into his last year of his 10 years with us. He's also the ophthalmologist in chief of the University of Toronto affiliated Kensington Eye Institute. He was president of the COS from 2004 to 2006. And he's also president of the Canadian Association of University Professors of Ophthalmology. And he has been co-chair of the Eye Health Council of Ontario. Now, Sharif is known for his superlatives, but I personally think no one is more deserving of superlatives than Sharif himself. He is passionate about medical education and resident education. He is extremely dedicated to our department, and he's an amazing mentor to me, as well as many or most of our department. And to top it off, he's a wonderful and genuine friend. I think we are all extremely interested in the work he is doing to understand Ontario's need for ophthalmologists. As residency PD, I'm hoping for a very good outlook for all our upcoming graduates. So thank you, Sharif, for this work, and we're all very interested into what you're going to tell us this morning.
Thank you very much, John, for those kind words, and welcome everyone to our inaugural rounds. As you know, we'll be doing these rounds over Zoom for at least the rest of this year, and then maybe go to a combined model. We're going to start off rounds today talking about our ophthalmology workforce and our ophthalmology human resources. We're going to be looking specifically at Ontario, but I think Ontario is very representative of the rest of Canada in many ways. And we have 3 presentations by 2 medical students and 1 of our residents who have done a tremendous job in researching this topic. I wanted to just quickly introduce some of the panelists that you might not be familiar with and who were very kind to join us today. I'm just going to go around these Hollywood squares in the order that I see them. And Yvonne Buys is with us. I think most of you know Yvonne very well. She's been a strong member of this department for many decades. She's past president of the Canadian Ophthalmological Society and has recently retired from clinical practice, but is probably more active than ever in research and playing a national role in our ophthalmology society. We also have Phil Hooper from London. Phil is a past chair of Western Ophthalmology, and he is the chair of advocacy with the COS. Phil has played many decades in leading many ophthalmology processes. He is currently the ophthalmology lead with the Ontario government. And Phil, thanks for joining us this morning. Rob Campbell is with us. Rob is the deputy head at Queen's University, Department of Ophthalmology. Rob is an ISIS scientist and has published significantly on health human resources in Ontario and commented widely on our human resources across the country. And we also have Rich Weinstein. Rich, thanks for joining us. Rich is the current president of the Eye Physicians and Surgeons of Ontario, and we'll look forward to some of your comments about these human resources. So we're going to have 3 presentations. First one, we're going to look at demographics. The second, we'll look at characteristics of the demographics of our ophthalmology workforce. And third, the geographic and regional variation. And we're going to start with Aman Sale. He is a medical student here at UofT. He's done a spectacular job at this research. And Aman, why don't you start us off with your talk?
Sounds great. Just going to share my screen here. All right, can you all see this? All right, good morning, everybody. My name is Aman Sale. I'm a 3rd-year medical student at the University of Toronto. Very honored to be given the opportunity to present this research that we've been able to work on over the past 1.5 years. Today, I'm going to tackle the supply of Ontario's ophthalmologists over the past decade, and just a very, very big thank you to everybody here listed on this slide, as well as to the OMA, EPSO, and the Ministry of Health. So why is this a topic that we decided was worth exploring a little bit more? Well, ophthalmologists provide most of their care to seniors. And a fact that I found very interesting was that aside from geriatrics, ophthalmology is the next specialty in line to deliver most of their care to the elderly. And they actually deliver about 11% of all health services received by the elderly in Canada. And if we look at the left-hand side, we can see that our demographics are really changing quite rapidly. We actually have a quite aging population. And by 2041, it's projected that approximately a quarter of the population will be in the 65 plus cohort. And what makes this particularly concerning for ophthalmology is that when we consider a lot of the bread and butter in the field, like cataracts, glaucoma, AMD, diabetic retinopathy, a lot of these conditions have age as a very prominent risk factor. So really the goal of our research that we're presenting to you today is to better understand how various facets of health human resources have changed over the past decade, so we can make better projections for the future regarding the needs. And really the end goal is that we want every Ontarian in the province in the decades to come to receive the best quality of care that they can and care that's delivered in a timely manner as well. So we used billing information from OHIP, and OHIP has been validated as an excellent source of information to characterize a physician workforce. And the Ministry of Health provides this OHIP data that we needed to the OMA on a monthly basis. And we provided very exact instructions to the OMA regarding the exact data that we needed. We looked at all ophthalmologists practicing in the province over the past decade, and we collect population estimates from the Government of Canada website. So we define an ophthalmologist as one if they were a physician who is defined with a unique ophthalmology specialty code. So here in Ontario, anybody who's an ophthalmologist, whenever they submit a billing claim, they have that number that's associated with their billings, and that number is 23. And if you were identified with that number and you submitted greater than or equal to 100 billing claims, you were an ophthalmologist in our project. And what we did was we took that cohort of ophthalmologists and we categorized them into very specific areas of care using very exact definitions, like neuro ophthalmology, glaucoma, comprehensive cataract surgery. And what we then did was we calculated the supply of ophthalmologists per 100,000 people overall within each area of care in each fiscal year. We then repeated this analysis only considering those who are 65 years of age and older, because once again, like I was mentioning, this is really the cohort of the population that is utilizing ophthalmic services at a much greater rate than the rest of the population. And really the most important thing for us was we really wanted to see how trends have changed over time. This is an example of our category definitions and coding details for various areas of care. It was very complex. And one thing I should mention before I get into this is that there really is no perfect way to identify who an ophthalmologist is in a certain area of care. I'm sure if you ask 10 different oculoplastic surgeons what they thought about our definition, you may get some very different opinions there. But we did our best to reach out to as many subspecialists in the province as we could. We got excellent feedback. We validated the appropriateness of our definitions, and we actually made some changes, and it was really excellent feedback that we got. And as an example, in the light gray boxes, these are our subspecialty areas of care. For example, if we look at corneal surgeon, we included someone as a corneal surgeon if they did greater than or equal to 10 corneal transplants in one fiscal year. And these are the corresponding OHIP code billing details for those corneal transplants. In the dark gray boxes, we can see our generalist ophthalmologists. So for example, our low, moderate, and high volume comprehensive cataract surgeons were those who did between 1 and 200, 200, 800, and over 800 cataract surgeries in one fiscal year and didn't fit into any of these above categories. Finally, we did have a general medical ophthalmologist category, and these were ophthalmologists who didn't fit into any of these above categories. They didn't conduct any ophthalmic surgery, and they did greater than or equal to 100 ophthalmic consultations or assessments. These are the results for the number of ophthalmologists per 100,000 population. There's a lot going on this slide, so I'll walk you through some of the key points. First of all, on the right-hand side, we see our stacked bar graph corresponding to supply. Each segment we see here corresponds to a specific area of care. The largest areas of care are at the bottom, and as we work our way towards the top, they get smaller and smaller. And I think something we can all appreciate here is that when we look overall, we're not really seeing a big difference in the supply over time, only about an increase by 0.7%. And when we dive into the areas of care a little bit deeper, we notice some very interesting findings. We can see the top 4 largest areas of care encapsulated by this smaller rectangle here. These are all our generalist categories. So our low, moderate, high volume comprehensive cataract surgeons, as well as our general medical ophthalmologists. And it's really this cohort of generalists that comprise the greatest proportion of ophthalmologists practicing in the province of Ontario. And this largest category down here, this is moderate volume comprehensive cataract surgery. This is also the area of care which saw the greatest decline over time. And one of the arguments we got was that, is this really a decline in the supply of moderate volume comprehensive cataract surgeons, or are we just seeing shifts between the low and high volume comprehensive cataract surgeons, which is a very good point. So what we also did was looked at the supply of all comprehensive cataract surgeons together as one cohort, and we still saw a significant decline by about 9%. The three areas of care where we saw the greatest growth over time were low vision, glaucoma surgery, and neuro ophthalmology. But there's really a lot of factors that we must consider here, which contributed to the inflation in these numbers. And I'll get to this in the coming slides. Now, this paints a very, very different picture than what I just showed. And, we can really see when we look at the supply of ophthalmologists per 100,000 people, 65 plus, we actually see quite a sharp decline over time over the past decade, about a decrease by about 18.4%. Once again, our moderate volume comprehensive cataract surgery category saw the greatest decline by 35.4%. When we look at all surgeons, all comprehensive cataract surgeons as one cohort, we still see a very hefty decline by 26.2%. And what really distinguishes this supply that's targeted, the supply analysis, which is targeted at our elderly cohort compared to the previous analysis, is that we're not just seeing supply reductions in our generalist categories, we're seeing supply reductions in almost every single area of care. And the only three areas which showed positive growth were low vision, glaucoma surgery, and neuro ophthalmology, which once again, there's a few considerations which I'll get into. So what's this magic number of ophthalmologists that we should be aiming for? I spoke a lot about trends and how our numbers have been changing, but what's this ideal number? Well, the Royal College in 1988 indicated that 3.37 ophthalmologists is that magic ideal number. But we really have to consider a few things when interpreting this value. 1988 was not a short time ago, it was quite a long time ago. Ophthalmology has changed a lot since 1998, and which requires more frequent interactions between patients and their ophthalmologists. And I think the really most important fact here is that this number did not consider the realities of a rapidly aging population. It considered that all members of the population would utilize ophthalmic services at an equal rate, whereas like I've mentioned, by 2041, 25% of the population will be in the 65 plus cohort, and this is the cohort that utilizes ophthalmic services at a much greater rate. So perhaps a more valuable benchmark should be the number of ophthalmologists per 100,000 people, 65 years of age and older. This would be ideal, but unfortunately, we don't have this data in the literature. We don't have this metric to compare our data to. What we can see is that, the supply is decreasing, and it's decreasing quite rapidly. Over our study period, it was 18.4%, and it's projected that into 2030, we'll see a further decrease by about 22.1%. And, this, ophthalmology as a specialty, we really could land ourselves in a very problematic situation if we really don't look into this data further and try to see where we can make some change. So why do we see this reduction in generalists? And when we look at data over the past decade, we can see that the majority of residents who are graduating from ophthalmology programs are pursuing subspecialty training. The difference between those pursuing subspecialty training and comprehensive training isn't that great. So I don't know if this could be the largest contributing factor to this supply gap, but we're also seeing a possible reason could be that more comprehensive ophthalmologists are retiring than those who aren't comprehensive ophthalmologists. And if this supply gap isn't being filled by more comprehensivists, this supply gap will just widen. And I was discussing about neuro ophthalmologists, glaucoma surgeons, and low vision ophthalmologists, and why we saw such large percentage increases in these specialties. One of the reasons is, these specialties were also the smallest that we had in terms of areas of care. So for example, if we look at low vision, if low vision had 5 ophthalmologists in 2010 and 6 ophthalmologists in 2019, even though there was only an absolute increase of about 1 ophthalmologist over the past decade, that's reflective of an increase of about 25%, which sounds like a lot, even though it's only an increase of about 1 ophthalmologist. Neuro ophthalmology was a special situation because we had the consult code A231, which was introduced into practice early on in the study period. So what we saw was that from 2010 to 2013, we saw a growth of like 30% of neuro ophthalmologists, but from 2014 to 2019, we saw almost no growth. So really, when we look at the overall growth of neuro ophthalmologists, this likely isn't a true increase. It's likely rather the uptake of this new consult code into practice early on in our study period. Then we had glaucoma surgery, which once again had a very interesting case where microinvasive glaucoma surgery really took off over the last few years. And when we have comprehensivists who are conducting MIGS, there is no specific MIGS billing code in Ontario. There's some research into the development of one, but we don't have one. So we have comprehensivists who are billing these glaucoma filtering codes, and they're subsequently being captured in that glaucoma surgery category. One of the limitations of our study is that not every single definition is mutually exclusive. And the reason for this was if we apply this criteria to every definition, it will get very technically difficult. And our folks at the OMA had to code our definitions, and this would get very, very complicated. So what we did instead was we set a significant threshold for the number of performed services. This way, we weren't including anybody who was being captured into a category if they were conducting any billing errors. And we really didn't want to be including anybody who only had an interest in a specific area. Rather, it was their primary practice focus. So this is a lot of information over the past 10 minutes, but I think really the take-home messages are that we're seeing an overall decline in the supply of generalists in Ontario, specifically with comprehensive cataract surgeons. And when we look at this population, 65 years of age and older, this cohort that uses ophthalmic services at a very high rate, we see substantial supply reductions in most areas of care. Thank you very much. It was a privilege to be able to share this information with you all. And I'll open the floor to some discussion points from our panelists, and definitely can take some questions as well from the audience.
Thank you, Emin. And I just to reiterate those points that you raised, while our number of ophthalmologists in the province really hasn't changed over the last decade, and actually hasn't changed much over the last 30 years, we're seeing a reduction of almost 30% in the number of ophthalmologists per 100,000 over 65. And the other interesting thing you highlighted is that our ophthalmologists, our general ophthalmologists that do cataract surgery are slowly segregating into those that do low volumes and those that do high volumes of cataract surgery. And we're losing the numbers of that group that do between 200 and 800 cases a year. So that's very interesting material. I wonder if we can start with some of our panelists commenting on this. Yvonne, what do you think of these numbers going forward? And is this, are we going to be running into problems with this?
Well, I think it's all very interesting. And right now I am looking at the national data. And of course, I am not able to break it down by subspecialty. But if I look at the numbers that we have nationally, they really mirror what you're showing here for Ontario. Like you said, Ontario represents about 38% of the population. So that's not surprising. You know, the challenges are, what is that ideal number? You know, of physicians per 100,000 population, or maybe more importantly, physicians per 100,000 population over the age of 65. And the other thing is to look at your age demographic of your ophthalmologists, because you said in 2040, a quarter of the population will be over 65. Well, right now, about 20% of ophthalmologists in Canada are over 65 as well. So I think that we do have potential challenges, but it's really hard to interpret manpower data because we don't have any metrics to measure it. And the other huge unknown in what we've discussed is, what about the role of optometry? So in my last study I did looking at optometrist number, every 5 optometrists to 1 ophthalmologist, and what role do they play in vision care to help offset the potential issues we may have by not having a sufficient ophthalmology workforce. So excellent data, you know, it makes you think about a lot of things, but it almost raises more questions than answers at some times.
Thank you. Phil, anything to add?
No, I find it very interesting data. I think the data with respect to potential shifts in what people in general ophthalmology practice are actually doing is interesting. One of the corollary questions it raises as you see the number of high volume cataract surgeons go up is, what proportion of their time is available to do other things that a general ophthalmologist does. And that's been something that's been debated back and forth as well. So as Yvonne said, the data is interesting, but it raises probably more questions than it answers.
Thank you. Let's go on to the next talk, and we'll get commentary from the rest of our panelists after the next talk. Our next talk is going to be presented by Yusuf Ahmed, one of our UofT medical students, and Yusuf comes from a pedigree of ophthalmologists, and so Yusuf, take it away and fill us in on some of the demographic characteristics.
Sounds great. I'm just going to go ahead and share my screen. All right, everyone. So hi, my name is Yusuf Ahmed. I'm a fourth-year medical student at the University of Toronto. And on behalf of our team, as Amin said, we're very thankful for the opportunity to be presenting our data today. And I'll be discussing the second phase of our project, which more focused on the demographic trends in Ontario's ophthalmologists from 2010 to 2019. So as Amin mentioned, Ontario's population is aging, but what exactly do we know about Ontario's ophthalmologists? And Dr. Baez kind of alluded to this as well. It's important to understand Ontario's ophthalmologists to provide context to what Amin discussed earlier. What do we know about the age of these ophthalmologists? What do we know about the sex distribution of these ophthalmologists, and so on? This is especially useful in terms of career stage when we try to give context to the overall ophthalmology supply and also prepare for the future delivery of ophthalmic services. And with respect to gender, we know that ophthalmology has been historically somewhat of a male predominant profession, that efforts have been made to improve the gender distribution in terms of female representation. But do we know if these efforts have been making tangible change is the question. With these questions in mind, the aim of our study was to explore the demographic trends in Ontario's ophthalmologists and see how they've changed from 2010 to 2019. So I won't labor you with an explanation of the whole methods again, as Amin already touched over that, but I will go over the specific methodology with respect to the demographics that we looked at. So the two demographic variables we focused in on were career stage and sex, and career stage was defined based on age. So early career was defined as an ophthalmologist less than 45 years old. Middle career was defined as an ophthalmologist between 45 and 55 years old, and late career was defined as over 55 years old for the ophthalmologist. Sex was defined as male or female, and the primary outcomes of this phase of our project were the change in ophthalmologist proportion across the early, middle, and career stage and late career stages, as well as the change in proportion and number of female ophthalmologists. And similar to what Amin went over in his past presentation, these primary outcomes were extrapolated across the different areas of care, such as comprehensive cataract surgeons, glaucoma surgeons, general medical ophthalmologists, and so on. So starting off with our first primary outcome, we looked at the number of ophthalmologists in the early, middle, and late stages of their career. And as you can see here on the slide in this figure, late stage ophthalmologists consistently comprised the greatest proportion and experienced the greatest rate of growth. Middle career ophthalmologists were actually the only career stage group to experience a decrease in supply and were overtaken by number of early stage ophthalmologists later in the study period towards 2017 and beyond. However, you can see that there's still quite a gap between late career stage, middle, and then the middle career and early career stage ophthalmologists. So now I'll get into a breakdown of the specific areas of care across each of the career stage to give you all the better context of what this slide and this figure really is showing. Starting off with the early career stage group, as I mentioned before, the overall proportion of ophthalmologists remained relatively stable over the course of the study period, and this also followed suit for the different areas of care. Something interesting of note, though, was that the low volume comprehensivists comprised the greatest proportion of all areas of care amongst the early career stage. And this is in comparison to what you see at the bottom of this graph, in that there are lower proportions of high volume comprehensive cataract surgeons in the early career stage bracket. Moving on to the middle career stage ophthalmologists, the overall proportion decreased by 7.6% over the study period. And it appears that a decrease in high volume comprehensive cataract surgeons amongst this middle career stage cohort was mostly responsible for this decrease that we saw. And you can see early in the study period in 2010, Middle stage ophthalmologists, high volume comprehensivists comprised the greatest proportion, but by the study's end, it had decreased almost in fact 20.2%. The other areas of care remained relatively stable with the exception of general medical ophthalmologists, which also experienced a 13.1% decrease in proportion. And last, of course, would be the late stage ophthalmologists. So this age cohort actually increased 6.4%. So the opposite of what we saw in the middle career stage. And this trend, opposite of what was seen in the middle career stage, was driven once again by the high volume comprehensivists, which experienced a 25.8% increase from 2010 to 2019. General medical ophthalmologists also experienced an increase in proportion, and they're the top line you can see on this figure. So they actually comprise the greatest proportion. But these trends that we are seeing, I guess to summarize, the decrease in middle career stage ophthalmologists essentially shifted over into the increase in the late career stage ophthalmologists. And this was because of what we feel is high volume comprehensive cataract surgeons aging out of their respective age cohorts into the late career stage. So looking at our second outcome, which was gender, this figure shows the proportion of females across the different areas of care over the course of the study period. And as you can see, overall, there was an increased proportion of female ophthalmologists from 18.7 to 24.1%. So there is an increase in representation. And not only was this seen overall, but this was seen generally consistently across all the areas of care. Most of the growth came from moderate volume comprehensive cataract surgeons. But an interesting trend we noticed, and this was similar to that noticed in the early career ophthalmology population, was that you can see female representation was highest for the low volume comprehensivist group and lowest for the high volume group. So as surgical volumes increased, female representation was slightly lower. And we'll get into discussing those trends and possible explanations in subsequent slides. Discussing our first primary outcome, which was career stage. Essentially, to summarize, more ophthalmologists, as I mentioned, are moving from the middle career stage to the late career stage. And late career ophthalmologists are continually increasing in proportion relative to the overall supply. More young ophthalmologists are low volume surgeons, and more older ophthalmologists are actually becoming higher volume surgeons. And the number of ophthalmologists in the late career stage bracket raises several questions and implications, both in the short term and the long term. In the short term, younger graduates coming from Ontario's ophthalmology residencies may possibly see an increased difficulty in securing OR time. And this was alluded to in a COS survey that was sent out from 2012 to 2015, which showed a 10% decrease in quote unquote success at finding a full-time job with OR access privileges. Thinking longer term, we can expect the retirement rates to increase over the next decade because of the increased proportion of late-stage ophthalmologists. And this also raises several questions to think about. The first being, who will replace the retiring ophthalmologists? And do we have enough young ophthalmologists to replace the retiring subgroup and the services that they provide? There's also a question of how we should be replacing retiring ophthalmologists. And there's the question of how we will care for patients who oftentimes have to scramble when a new ophthalmologist, when their old ophthalmologist retires and they have to find a new one. A possible proposition to mitigate this issue could even be a job sharing paired system where a new staff overlaps with a retiring staff for a specified period to transition their patients over to that new staff to avoid doctorless patients, if you could call that. And further questions include whether we should be creating more OR time for younger ophthalmologists and perhaps even more importantly, asking where we should create more OR time for younger ophthalmologists. And I won't spoil Marco's talk, but the geographics play a very important role in thinking about the answer to this question. And of course, all of these questions go hand in hand with the importance of pushing for governmental policy change to increase funding for surgical services in the province. For gender, we found that there was an increase in female representation, both overall and across the areas of care. And this is likely because, as you can see on the right side of the screen, more females are applying to ophthalmology residency. And this is really a trend that started in 2005. females are still slightly underrepresented and compared to other surgical specialties such as urology and thoracics. However, we feel that considering the promising residency data, the residency population will be reflected in the staff population in the coming years, and the female proportion will continue to rise. As I mentioned as well, an interesting finding in our study was that amongst female ophthalmologists, there's a smaller relative proportion in the high volume comprehensive cataract subgroup. And future investigation into why this is the case, for example, is it lifestyle factors? Is it personal choice? Is it hiring factors? Is it an equity issue? And so on. Finding the answer to this question will be useful to determine if we should direct our efforts to, for example, improve hiring practices for both sexes in the future. As far as limitations go for this phase of the study, it more focuses on the definition that we provided for career stage, as we used age as a criteria for career stage and not number of years in practice. And while early, middle, and late career stage are arbitrary and may not completely correlate with age, we felt that using age was a suitable option because it reflected the bracket of new grads and the age at which ophthalmologists may begin to retire appropriately. So that's why we chose to use age. In conclusion, our study demonstrates that there's an increasing proportion of late-stage ophthalmologists, and this is it also goes hand in hand with the increasing proportion of ophthalmic services being provided by this age cohort population. And as this cohort begins to retire, there may possibly be a mismatch in services versus demand, but proposing possible solutions to mitigate this mismatch would be an important consideration going forward, and answering some of those questions I went over in the previous slide would be a benefit. With respect to gender, female representation is improving and will likely continue to improve as residency trends are reflected in the staff ophthalmology population. But finding the answer to the question as to why there are lower female proportions in higher surgical volume settings would be a benefit to try and see if we need to address anything going forward. So that's my my portion of the presentation. Feel free to email if you have any questions, and I'll leave it up to the panelists to take it from there.
Thank you very much, Yusuf. That was a great presentation. And really two big points. Let's focus on the first big point, which is Ontario ophthalmologists are getting older, and we're at a majority over 55. And those ophthalmologists are doing the majority of the cataract volume. They're the high volume surgeons, and the cataracts have gone with them. Rob, what do you think of this trend? And given that we produce only about 12 to 13 new ophthalmologists annually in Ontario, could we be in trouble going forward?
Thanks, Sharif. Yeah, I think the first comment I'd make is, thank goodness, older surgeons seem to do a good job. The data suggests that outcomes are just as good pretty late into your career. So if we're dependent on late career surgeons, we don't face a quality issue. So our bigger issue is going to be quantity. And like you said, can we provide service everywhere we need to? And I think that if you go back to the first presentation, it's amazing how consistent the numbers have been in absolute terms across the province. So it shows that the numbers are not being driven by the age of our population or even the number of surgical options. It's really being driven probably by OR time. Can you get a job or not? And as somebody retires, somebody replaces them, and that's about as much effort as we put into deciding how many we need. And clearly, as you've shown, if our population's aging and we have more surgical things we can do than we could 20 years ago, we're going to need more surgeons, not just an equal number. So I think that if you look at those numbers, and with 12 or 13 grads, it'll be touch and go over the next few years. I think that the new grads should have choices about where to go as people retire, assuming they retire at the kind of age we typically have. But the other option is people may keep working longer as well, and whether they choose to. So there's a lot of variables, I think, that makes it hard to know for sure if there's going to be a loss. But certainly there's going to be a need for more people, and whether it's work later or transfer earlier, it's hard to know.
Thank you. we've had a couple of comments from the audience. I think Brad just wrote he's been hearing about this problem ever since he was a resident, about the aging population. And you know, well, Brad, I think you're right. It has been a problem for many, many years, and I think it's a worsening problem as we go forward. If you look at the statistics, we're doing each ophthalmologist is doing significantly more work now than in the past, maybe up to 40% more work. And the numbers continue to skew towards our older demographic. And so there is a concern that if this continues, we might have a situation where we're unable to provide care. Yvonne, do you think, that this is an issue, or do you think that this is just a trend that is going to continue and we're going to continue to supply? And the other point I wanted you to comment on, what do you think of, you know, we look at female surgeons, and they really make up the low volume surgeons more than the moderate and high. Why is that? And do you think that that's something that's going to change in the future?
Okay, so first, let's tackle about the age trends. I think that is something that's going to continue. And I think it's not unique to ophthalmology. It's not unique to medicine. People are extending their careers. And that's partly because our average life expectancy is longer as well. So I think it's a good thing. I don't think there's a problem with that. We don't have a forced retirement. And as Rob said, his research has shown that older surgeons were as productive, effective as younger surgeons. So I think that that's not a problem at all. I think one thing that we haven't said, like we're also concerned, are we not going to have enough surgeons, was from the first presentation when you saw nearly a third of ophthalmologists were not performing surgery. Well, isn't that an opportunity? What if we could convert those people into surgeons? Because our whole kind of word of what is an ophthalmologist compared to an optometrist, it's surgery by surgeons. So if we could maybe have all ophthalmologists perform surgery, we have a big opportunity to deal with some of these potential issues that we're raising. So that's the first part about age. Now, the second part about gender, and I'm wondering if I could, let me see, share this slide that I've been working on. So if you can see that, this is the Canadian data, a snapshot from 2019. And although Ontario is doing pretty well, we're still below the national average. So I know that you mentioned, Yusuf, that efforts were made to improve female distribution. I'm not sure that there were any efforts. I think that this all just happened naturally, which I think is actually a good thing. I think you should only be taking in the best qualified residents and not making discrimination by gender or other things. So our numbers, our proportion is improving over time. I think I have that over here. And the yellow is ophthalmologists in Canada, but we lag quite a bit behind all other specialists in the gray line, all Canadian physicians, and of course, family physicians, which has a larger proportion. But the other thing that you were asking was, why are female ophthalmologists underrepresented in certain surgical areas? And I'm not sure if any of you have read my recent publication in the COS, basically looking at the gender pay gap in ophthalmology in Ontario. And I allude to what I think the issues are surgical access. I think for some reason, maybe is it during training that women don't feel maybe as comfortable to operate and are less likely to choose to operate? Or is there some type of barrier, either self-imposed or system-imposed, that prevents women from getting equal access to the OR, not just in terms of yes, no to the OR, but the proportion of time? And so I've done a number of studies that have shown that female ophthalmologists in Ontario are less likely to have OR time. And when they do, they often have less OR time than men. So I'm not sure why that is. Is it their choice or is there a barrier? But I do think it is something that we need to address. And we also at the same time need to address a similar thing for the younger ophthalmologists, of which the higher proportion are females compared to our older ophthalmologists.
Thank you. Very true. I agree with that. Let us, for the sake of time, let us move on to geographic distribution. Then we'll come back to a full discussion of all the topics. So Marko Popovic is one of our residents here at U of T. And Marko, I'll turn things over to you.
Perfect. Thank you so much, Dr. Eldefraui, and thank you for the opportunity to present today. So let me just get this ready here. So I'll be speaking about the geographical distribution of Ontario's ophthalmologists during the study period. And before I start, I really just want to thank our whole team for making this project a reality. I want to thank the OMA and EPSO for their support as well in allowing us to analyze this data. So to start, during the study period, Ontario's provision and delivery of healthcare was subdivided into 14 different LHINs or local health integration networks. And the purpose, as I said, was to explore the geographical distribution of Ontario's ophthalmologists across these borders from 2010 to 2019. I won't go into an extensive discussion of the methods as you've heard these already, but I'll just highlight that essentially the only change in this phase of the project was that we took the number of ophthalmologists and categorized them into various LHINs based on their practice address. Our outcomes otherwise remain the same. So starting off with the proportion of ophthalmologists, as you see here, so relative to the 464 ophthalmologists that we accounted for in our study sample, what proportion are found in each LHIN? And so you'll see here across the 14 LHINs, essentially stable numbers over the study period. And then just honing into a few specific LHINs, these were the top 3 LHINs with respect to the highest proportion of ophthalmologists, specifically Toronto Central, our very own LHIN, and then the Central LHIN, so Newmarket and areas just north of the city, and then Champlain LHIN, so the Ottawa and surrounding areas there, rounding out the top 3. Looking at the 2 lowest LHINs in terms of the same metric, it was North Simcoe Muskoka and Northwest LHIN, which is located all the way to the very north of the province. We see not only for North Simcoe Muskoka do you have at baseline in 2010 a low proportion of ophthalmologists, but a declining ratio over the study period. Next, looking at the number of ophthalmologists per 100,000, and so you have already heard the stability of this metric in a general sense, but when we break it down into LHIN, I think the same conclusion holds true, that generally we didn't experience any major changes with respect to LHINs over the study period. And once again, honing in on specific LHINs, you'll see the top 3 here, very similar to what I presented earlier, Toronto Central and Champlain, both making it into the top 3 here, as well as Southeast LHIN, so Kingston and the surrounding areas. Looking at the 2 LHINs with the lowest number of ophthalmologists relative to the population, it was again North Simcoe Muskoka, as well as Central East LHIN, so Peterborough and areas just east of the city. Next, looking at the number of ophthalmologists relative to the population 65 and over, again, this declining trend over time was definitely evidenced across all LHINs. There was not a single LHIN that experienced a growth in this metric, though there are important trends to clarify when looking LHIN by LHIN. First, looking at the top LHINs, again, Toronto Central, Southeast, and Champlain, as we've mentioned before. In Toronto Central, the decline was about 9% over the study period, and it was the decline was more pronounced in other LHINs like Champlain here, which experienced a decline on the order of 20%. In terms of the LHINs with the highest decline over the study period, those were these 3: Hamilton, Niagara, Haldimand, Brantline, Central West, so Peel region, and then North Simcoe Muskoka. And you'll see that all 3 of these line graphs here are clustered at the very bottom of the graph here, indicating that at baseline, all three of these limbs have relatively a low number of ophthalmologists relative to the population 65 and over, and also significant declines, anywhere from 25 to 40% declines in this metric amongst these three limbs. And so then subdividing in terms of generalists and subspecialists, here we see Toronto Central at the very top here, much higher than all other LHINs below, affirming the notion that in our own LHIN, it's not only that we have a high number of subspecialists, but we do actually have a lot more comprehensive ophthalmologists practicing than virtually any other LHIN in the province. And then here, looking at the number of subspecialists relative to the population, this is where you see Toronto Central at the very top here, a significant difference relative to virtually all other LHINs, essentially a threefold difference in Toronto Central versus all other LHINs, accounting for some level of LHIN to LHIN variability. We do see some level of stability over time, LHIN to LHIN, though there are some important differences. North Simcoe Muskoka LHIN at the very bottom here, experiencing not only a baseline low number of subspecialists, but also a declining rate to zero by the end of the study period. So just to discuss this section of the project, relative to that ratio proposed by the Royal College in 1988, there were only three LHINs that actually met that 3.37 number of ophthalmologists per 100,000 population. Those are Toronto Central, Southeast, and Champlain. And it's no surprise that these three regions are associated with a residency training program. Collectively, these three regions account for about 20% of Ontario's population, but more than 40% of all ophthalmologists. Making a comment about subspecialists, and I know there were a couple of comments about subspecialty representation in the chat. We found overall that there was a good coverage among subspecialists. Three subspecialties that I'll just highlight here are low vision rehab, neuro ophthalmology, and pediatric ophthalmology. First, in terms of neuro vision or low vision rehab, they were not found in most LHINs, and the projected demand for these services are estimated to grow by about 30% over the next decade. In terms of neuro ophthalmology, it's important to highlight a limitation of our approach, which is that given that we included only ophthalmologists in our definition, that specific code was tied down to anyone who had an ophthalmology residency and then neuro ophthalmology fellowship, as opposed to looking at any neurology trained neuro ophthalmologists. And then in terms of pediatric ophthalmology, we saw that pediatric ophthalmologists were represented at about half of LHINs studied, though in some regions that they were represented in, the supply of pediatric ophthalmologists was short. So one of the local vision task force reports for the Champlain LHIN noted that though they have pediatric ophthalmologists, the wait times for strabismus and other pediatric procedures was quite high given the excess demand relative to the supply of these subspecialists. And one of the things we want to note here is that we're not advocating that there should be a subspecialist for each subspecialty at each LHIN, though some of these trends are interesting to analyze. Just concluding on our own LHIN, Toronto Central, not only did we have a very high proportion of subspecialists, but also generalists, ophthalmologists relative to the population, and then relative to other LHINs, a relatively low decline relative to the population 65 and older. Hamilton, Niagara, Haldimand, Brant LHIN is one that at baseline has a very low subspecialty representation, and also one of the highest decreases in terms of generalist supply relative to the population 65 and over. Just a general point here to make is that the Ontario Vision Task Force, when they looked at human resources trends back in 2013, one of their recommendations was to ensure an adequate supply of ophthalmologists in the province that recruitment of around 2 to 3 additional ophthalmology residents per year would be needed. And since the publication of that report, only about half of a resident increase per year has actually been manifested on average. In terms of Southwest LHIN, so London and the surrounding areas, they had a fairly low generalist supply, and their local vision task force recommended adding a further comprehensive ophthalmologist to this area. For Erie St. Clair, this is a region that had the highest ratio of subspecialists to generalists, it's an area that has interesting trends in terms of their ophthalmologists. So how the model of care that's practiced in this LHIN happens is that what we're seeing is that the comprehensive ophthalmologists here are essentially all high volume cataract surgeons, meaning that subspecialty, the care of various subspecialty conditions are left to the individual subspecialists. So then moving on to the northern regions of Northeast and Northwest LHINs, as you know, these are very sparsely populated areas that have a high incidence of chronic health comorbidities, including diabetes, and barriers to eye care in remote communities. They did have a reasonable number of comprehensivists, though a low proportion of subspecialists. Currently, subspecialty care in these two LHINs happens by patients traveling either to Winnipeg or to Toronto to receive their care. And one of the findings of our report is that potentially there may be some room to establish a local area, whether it's Thunder Bay, Sudbury, Sault Ste. Marie, where there could be some level of subspecialty representation here for these patients. So just to conclude, in terms of our limitations, one of the facts that we assumed was that all physicians were equally productive, and that this may not necessarily be the case. Secondly, as I've alluded to already, patients travel from LHIN to LHIN to receive their care. And so what we're representing here is just the supply of ophthalmologists and not necessarily representing the demand that these ophthalmologists provide. As we know in our own LHIN, ophthalmologists in Toronto are providing care not only to patients from Toronto, but from the rest of the province, nationally, and sometimes even internationally. So to conclude, we did notice differences in terms of the supply of ophthalmologists in the province over the study period. And our goal really through this project and the other phases you've heard about is to inform future vision care plans and to ensure that all patients in Ontario receive the right care at the right place and right time. I want to thank you so much for your attention today, and I'm really looking forward to hearing the discussion on this topic and answering any questions that you might have.
Thank you very much, Marco. There's a lot to digest there, but why don't we look at a couple of points. First, being pediatric ophthalmology, and Stephen Kraft has brought this up as well. We see that there is an underrepresentation across the province in many areas. There's no pediatric ophthalmic surgery happening, and we see a very significant backlog. It's a multifactorial problem. But Rich, is there a way that we could tackle this in the province to deal with some of the surgical backlogs and access to pediatric ophthalmologists?
It's a great question. First, I commend all of you for the research. I'm fascinated by it, and I give you credit for using the OHIP billing data as opposed to anything else, because I'm always concerned when I look at any research and wonder what the data in is. So bad data in, bad data out. But I think the data in here is actually completely on point. Sharif, if you look at ophthalmology, we are unique in that 1 out of every $5 in our global budget is maybe even more if you counted the assessment codes, is spent on cataract surgery. So, and if you look at all of your conversations this morning, most of it is actually geared around access to the OR, which is always geared to access for cataracts. And my position here is rather unique because I didn't train in Ontario, I didn't train in Canada, I trained in Philadelphia. And I remember coming back in 2000, 2001 and how difficult it was to get a job. So you sort of wonder if you had more open market forces, if cataract surgery one day wasn't done in a public system or was done in a public-private combination and you had IHFs, would you have less limitations on people or new grads getting access? And if you look at the pediatric numbers, Human nature being what it is, I think if you don't incentivize people to do these procedures or to go into these specialties, they won't. And even at EPSO right now, Sharif, that we're talking about how can we potentially incent more people to go into specialties that are lacking or subspecialties that are lacking. So certainly, the pediatric numbers are concerning, but we have to figure out a way how to incent people to do these things.
Thank you. That's a good point, and we are looking at some paradigm shifts that might change our resources significantly, and so time will tell where our models go in the province, and that might radically change things. Phil, I wanted to ask you. The Vision Task Force had made some recommendations in their report in 2012. Regarding the supply of ophthalmologists, and yet these recommendations really haven't come to fruition. Also, there's been steps that the Vision Task Force took, which I think were excellent ideas. The idea of having each LIN look at their own human resources and come up with a plan. We saw plans come up from the regions across the province, but do you think these plans will actually turn into a productive way to provide appropriate human resources, or do you think that we need other strategies to be able to deal with this issue?
I think there's been a lot of planning, in quotation marks. There hasn't been a lot of traction from the planning. I think some of the things that have been helpful across the province has been the New Grad Initiative, and that was spearheaded by the task force as well as EPSO. And I think that has resulted in new positions being created, or at least a high degree of attention on getting new people into roles in the community. As far as the LIN planning process, there were about a third of the LINs that made specific recommendations with regard to increasing the number of ophthalmologists in practice. There are 3 LINs that have actually taken that to task and are doing things at this point in time to try to increase it. So it's not, in answer to your question, it's not been a very good uptake. I think one of the things that would be revolutionary and has been pushed, not a lot of uptake thus far at the ministry level. I think if you look across Ontario alone, there is excess training capacity in terms of the ability to put more ophthalmologists out each year. We're limited by a somewhat archaic system of defining how many residents each program takes each year that goes back to the 60s, and it's really based on a division at that time by the Ministry of Training. The ability to have training positions, if you will, sponsored by a region, I think is something that may need to be considered. It's probably the only homegrown way that you could fast track increasing the number of physicians in a short period of time. And it's something that we're pushing to try to see if it can get any traction.
Thank you. We're hitting almost time now. I think several things come up. I think looking at the regional and geographic distributions, we realize that given the vast spaces in Ontario and in Canada, it's very hard to go to just a subspecialist type of service. We need our comprehensive ophthalmologists in order to provide a full range of activity, and that includes strabismus surgery, glaucoma surgery, and oculoplastics surgeries to a limited amount. We also need to incentivize these, and I know Rich and EPSO and the current membership and the past membership, we've tried to incentivize things like pediatric ophthalmology, and of course you do that by adjusting fees to make it a reasonable thing to pursue. And this continues, and hopefully we'll see some uptake in some of the areas that we're lacking. We are also, I'm quite concerned about the numbers. I think we do not have the right residency output to meet the demand that we're going to see in the future. Over the next 20 years, we're going to see a significant increase in the demand for ophthalmic services. And I think the rate that we're going right now, we're just meeting our current numbers and staying at the same number. And in fact, as we see this aging cohort, the 55 and over the next 20 years retire, I think we could be in a situation where, worst case scenario, we could be down by about 50% of our need. And so I think it's really important that we have discussion between societies like EPSO, the Vision Task Force, and the COS to look at human resources and look at ways to get more ophthalmologists into practice. As Rich alluded to, so much of ophthalmic care is linked to surgical access. This might radically change as our paradigms change. We've seen a move by the Ontario government to move cataract surgery into private centers, and this will change things if this is the direction we go. But given the way we do things now, and given the incremental increases, we're seeing small incremental increases happening in the province. As far as numbers, we need to look at a way to bring in more ophthalmologists and be able to provide them with an opportunity to do surgery. I think the initiatives for the new grads have been very good. And as Carla Lutchman mentioned, this is one of the reasons we've seen numbers of low volume new grads, but we have to look at more initiatives in which to bring in new grads and maybe provide some job sharing to bring in ophthalmologists into a community. We're already seeing several mid-sized communities lose some high volume ophthalmologists and not be able to replace them. And this has created some crises in some communities where you have an ophthalmologist that decides, I'm going to retire in 6 months. And there's no new ophthalmologist to fill the gap. And suddenly you have that entire patient load going to the emergency rooms for their ophthalmic care. It overloads the entire community of ophthalmologists, and it puts a tremendous strain on the system. I think we are at risk of seeing this more and more. And so hopefully we're going to start addressing some of these things. And I know much of the panel is involved in trying to find these answers. And I think they will find some good answers for us. So I thank the panel for joining us. I thank everyone in the audience for joining us. And I wish you a happy start to your weekend. Bye, everybody.
Hi, thanks for inviting me, and hello to all my old friends in Toronto.
Bye, guys.